First of all, I would like to thank the organizing committee once more, and I'm really glad to speak to this crowd here. I would like to thank especially Dr. Sparias and Dr. Patakos for the very kind invitation. I would like to congratulate them for the whole 2 days full time for valvular diseases. And I'm really glad to speak in front of Professor Dardas and of Professor Kilic, my friend from Turkey. And we welcome you as a society here once more. Thank you very much. So it's the hardest time because it's a lunch time, so I'll try to be really fast in my presentation. We know that we have several challenges, as we already heard previously, in several valvular heart diseases. One of them is the problem that we have in the tricuspid and mitral valves. So I would like to share with you some cases that are really interesting, and they are out of the box, out of the everyday clinical practice. This is a 48-year-old male patient. He had in 2017 systemic tuberculosis with heart and renal involvement. In the same year, he had also chronic kidney disease with a baseline of GFR of 30. In 2018, he had a tricuspid valve replacement, and he had from the surgeons I don't know if I can show this. I don't know if I can see. Anyway, I'll try to use this one. So he had the proto. Oh, okay, that's better. So he had a 31 biprosthetic valve, St. Jude 29 millimeters. I'm sorry, 29, due to the infective endocarditis, and also he had a post-ischemic stroke after surgery. He continued to smoke and he had hypertension. He had a relatively young male with all these problems, and he had these presentations when he came to our center with a normal LV size, preserved systolic function. However, the tricuspid valve, the biprosthetic valve, there was a deterioration, severe stenosis, and moderate to severe regurgitation. And you can appreciate the high velocity in the tricuspid valve. I'll try to adjust it. So I think it's clear that the patient needs to do something. We had a discussion to proceed, and the decision was to proceed with a transcatheter tricuspid valve implantation with a balloon expandable valve. We used the Myval, and this is, I think, an advantage of Myval, that you could, even in case you have any problem, especially not everyday practice, you can retract it from the sheath and then reschedule the procedure. And we have excellent experience with that valve. So there was a selection. Another advantage is you have the double sizes to select compared to the other conventional valves. So we did the CT. I don't want to lose the time. We did the analysis of the procedure, and as you may see here, there was not something fancy. We went through the tricuspid. We had an implantation there through a Landerkost wire, and you can appreciate the positioning deep in the tricuspid valve. After echo in the ICU, within the valve at the tricuspid position, there was a protrusion of an echo-dense structure, provoking significant transvalvular gradient. No significant regurgitation. So there was a decision after we appreciate that to post-dilate it. So we post-dilated immediately after that, as you may see here, with an reintervention. You can appreciate there is always a waste there. We did post-dilatation, and despite our efforts, there was not perfect dilatation. However, echo and clinically, the patient fortunately went well. And this is some problems that you might appreciate in this in such cases. So, reduced surgery biprosthetic tricuspid valve failure is associated with high morbidity. In recent years, the valve-in-valve therapy using balloon expandable valves has become available, and of course, there was a careful procedural planning essential for valve-in-valve therapy. There is a second case, patient with replacement of mitral valve in 2012 with a 33 epic valve, St. Jude valve, and severe bioprostosis regurgitation. As you may see here, there was planning of the access, how we can go through this procedure. We know that valve-in-valve always is a better plan than valve in a ring. We have several problems in valve ring, but valve is more safe. I don't want to get into much details. I just want to share with you, this is the most important study demonstrating that valve-in-valve, as you may appreciate it in these graphs, the success rate is much higher than valve in ring and, of course, valve in MAC. This is a classical study. This is true. And the only problem that we have to deal with it is the concept of the neo LV outflow tracks, if we have an obstruction or not. These are the studies demonstrating all this. I don't want to lose time with this now. I'll go fast. As I told you, valve-in-valve is always better than valve in ring. So this is the case. Was NIHA class 3, severe bioprostosis regurgitation due to the leaflet prolapse. We had the pre-procedural screening. We did the outflow tract. Again, we were above 170, 180, so this is well done for the outflow obstruction. We use again the Myval 29, and you may see here we did the septostomy through the septum. We went to the LV. No significant problems. Here's the positioning of the valve, as you may see here, expansion, not significant problems, and the final result, as you may see here, very good hemodynamic result. I cannot, here, as you may see, zero gradient, very low LV and diastolic pressure with a very good result. So this gives us, again, the advantage, the valve, that we have several sizes, and the selection that we may retract it if we have any problem. And the two main problems are through the septum and when you finally go to the valve. The capillary measures for valve-in-valve are very good. This is again what we show with the aortic and mitral valve implantation. The New Heart Association is very well preserved during the follow-up. There are no problems. This again, valve-in-valve implantation in the mitral valve, 27.5. This is a registry that we also took part from Italy and from other countries, demonstrating the valve-in-valve implantation, the high success rate, the low events, and generally the experience that we share among us. This valve is very well preserved now for the aortic valve. This is a study that we had the letter for publication just yesterday, Professor Dardas, in the catheterization, so we just announced it for the first time. We show the effectiveness and safety of the Myval versus other contemporary valves in patients undergoing TAVI, so there's great experience in this area. So in conclusion, all these cases demonstrate that transseptal for the Myval, for the mitral, and also for the tricuspid valve, we can deal with this Myval new valve. The transcatheter valve-in-valve is a solution in these cases. Of course, there has to be careful pre-procedural planning with advanced imaging, as we always do, and it's very essential to optimize valve sizing, deployment strategy, and to mitigate complications. Of course, we don't have really long-term follow-up in these cases, but as there are difficult cases and they have a high risk for reoperation, I think there is a good solution. Thank you very much for your attention, and I'm open for questions.
Professor Louros, thank you for excellent presentation, for cases. A question. For the first case, in one direction road, the use of balloon expander valves, and yes, in one direction road, the use of balloon expander and not, let's say, an Evoke?
First of all, I don't have experience with Evoke. I think that Evoke has there's no experience for valve-in-valve implantation, as far as I know. Yeah. Okay. So it's only for native, and I think the only option that we have is balloon expandable valves. So that's why we use this one.
Okay. The question, yes.
Professor Kelic. Can we give you a microphone to Professor Kelic because.
Congratulations for the excellent two cases. Really, especially mitral valve-in-valve and valve-in-ring procedures are not easy procedures, and there are a lot of hard points, for example, especially crossing the septum and then crossing the valve, etc. And I think one of the main advantage of Myval is that the valve is crimped on the valve, and in any case of that you cannot cross the septum, you can pull back the Myval inside the sheath. And another good property is the intermediate sizes and extra larger sizes. And one of my observation of Myval also is the proximal part that we crimp the opposite side, as in mitral valve implantation. Proximal part is larger than the, for example, other balloon expandable valve, 6 millimeter. This can be an advantage for neo-LVOT obstruction. And what do you think about this?
Yeah, I mean, the first two advantages I mentioned. This detail, I didn't mention it. Of course, we don't have experience with the new Myval. I don't know if you have experience with the Octa, this new one.
Procedures, but not for mitral valve-in-valve.
I think the shortening there is less. So
or shortening is very less.
It's less, and so it's more predictable that you can do it. Yeah. But I agree with you that the opening of the distal part when we go to the mitral it might be an advantage regarding the LV outflow tract obstruction. Of course, we have to mention that if you plan to do such a case, you always have to trust the CT and the prediction of the outflow area. So we always go safely. I think it's above 250 is the safest, but above 170, 180, I think sometimes it's acceptable. But I think there is an advantage. We're waiting for the new generation who have some more experience. I fully agree with you.
Any other comment, question for this very nice case?
Kostas, or Toutouzas.
Say that these are the most difficult cases, the mitral valve cases, because a large portion of them have small ventricles, and there is a high risk of LVOT obstruction. And just to say that now we have the first commercially approved mitral valve for native anatomy, which is the M3, as you all know. This is a valve that we are awaiting. We have many patients with mixed mitral valve disease that have considerable MAC. And this case is a fair worst, whatever you do with valve in MAC. So hopefully this addition, the new valve, the M3, will give some better solution and option for these patients. We all await for the results of the study, the ENCIRCLE study. I think they will be presented at TCT, and FDA approval will follow the presentation of that study.
Yeah, I fully agree with that. Yeah.
Okay. Thank you very much.
Thank you very much for your.